Hey, everybody. Welcome to Leading Rural Healthcare, where we're having conversations beyond the margin. Every other week, we'll bring you real rural healthcare leaders with real challenges and real impact in their communities. I'm your host, Brendan Hurley, and today I'm with Karla Clubine, CEO of John J. Pershing Memorial Hospital, which is a critical access hospital here in Brookfield, Missouri. Karla is a board certified family pediatric nurse practitioner and has been Pershing CEO since 2021. As I mentioned to you, Karla, I know our listeners are really going to enjoy this conversation and your deep clinical expertise that now transitions into leading your community hospital. So, welcome to Leading Rural Healthcare, Karla.
Thank you. Glad to be here.
Yeah, so tell me a little bit, an icebreaker would be due. I mean, tell us a little bit about you, your background, uh, Pershing and Brookfield. I know you started in a clinical role like so many rural health leaders, right? You didn't necessarily go to school and have the thought to go straight into administration. So uh, tell me how you got here.
Well, administration was not at all on my list of career goals. Being in medicine always had been. As a teenager and things in high school, I actually felt like I wanted to go down the track of medicine and being a physician. And life happened, and things didn't kind of work out that way. And I did find nursing. And I think that was actually probably some divine intervention or providence there, because I think nursing was really the passion that I had, being able to be with patients at those critical times in their lives, when they're having those happy moments, but also some of those most tragic moments and things, was a role I really cared about, excelled at. And so then, as I was working as a nurse, I moved into the emergency department. And in that role, you could see the need for patients to be able to have primary care providers. It was getting very difficult at that time. And this is in the early mid to late 90s. We were already starting to see some struggles with people having primary care access. And so I learned about the role of nurse practitioners at that point. And so was very fortunate that Pershing allowed me the opportunity and actually even supported financially my decision to become a nurse practitioner.
Wow.
And so I did that track, and I am duly certified as a family nurse practitioner and a pediatric nurse practitioner. And when I finished school, there was an opportunity waiting here at Pershing for me in a rural health clinic. They had just started that rural health clinic. I was the first nurse practitioner for them to hire for that.
Wow.
And so yeah, that was a great experience. I was able to move from the emergency room into that rural health clinic and fill the need that I saw. A lot of people weren't having great access, and so this allowed them the opportunity to see someone a little bit quicker, have a nurse who has a different perspective sometimes in how you address people or how you problem solve with people. And being in a community small like ours, most of those people were familiar with me because at some point in time I had taken care of them in the emergency department. So it was a nice kind of complement to what I had already been doing. So
Yeah.
that's kind of how I got to that role. Again, leadership was not in my list of goals I wanted to accomplish professionally, but Pershing had always been very good to me and gave me opportunities at different times. So at one point, we were in between chief nursing officers, and the CEO came to me and said, "Hey, I know this isn't what we're paying you to do right now, but is there anything, would you consider maybe temporarily filling this role on an interim basis while we search so we can find the right candidate for our chief nursing officer?" And so I did. I think I spent 6 months maybe there, and they were very nice to allow me to do that on a modified schedule so I could still take care of my patients and
Yep.
then still be able to offer that support and leadership to the nursing department. So I was very happy to do that. I learned a lot in that role. And so other times things like that would come up. And so he would come to me again and say, hey, do you mind to do this? And so we kind of joked one day. I said, the only chair I haven't sat in this organization at this point is yours. When do I get the opportunity to sit in yours? And it was more of a joke, not really meant to be. And about 4 years later, he came to me and he said, hey, I know you were kind of joking, but,
4 years ago.
yeah, I'm looking to retire here soon. And I really feel like you would be a good person to lead the organization. And so,
Wow.
again, Pershing had always been very good to me. And when they ask, how
Right.
can I not feel that need when I know it's necessary and I believe I could do it. So that's
Yeah.
how I got that's how I got there.
Wow. Well, I'm obviously interested to ask. I mean, it's I wouldn't say extremely common, right? But when you talk to folks like John Doolittle, yourself, who not only have spent time, and you're different in that you've been in the clinician role, but now you get to serve your community as the leader of this hospital. There's got to be a tie there that no one else might be able to have, right? That didn't
Right.
come from the community, and you're in the emergency room, you're in the rural health clinic. You've really, to your point, served every role. How does a lot of those years being a clinician shape your role now as a leader?
I think it has been very helpful because I see the needs of the patient very clearly because I have had to, in my role as a nurse, because I think I'm a nurse first in all cases. You see the challenges that the patient has. You see, and so you're a problem solver for that.
Right.
And so bringing that into this role has been very helpful because then I can kind of sometimes weed through some of the minutia quickly and say, okay, no, this is what we need. This is the priority need for the patients. This is what we need for the health of the organization, or this is what we need for the health of the community. And I tell people I still go through the nursing process on about every decision I make. So we have to start off with that whole assessment thing and try to get to things pretty quickly there. But I think the clinical role has helped me to definitely be able to focus on the patient needs first.
Yeah. Well, and obviously you're wearing, two different hats. Well, or in this case, you're wearing the hat of the CEO leading this organization. How often, when you walk through that process that you're used to as a nurse, as a clinician, are those decisions put in conflict because of either financial constraints or other constraints that maybe you didn't even realize when you're in the clinician role, and it's a moment of epiphany, right? Where you're like, oh, so this is the challenge that those pesky administrators, right, have
Yeah.
to deal with. And I imagine, before you answer that, I mean, really, a lot of your colleagues, having been in that position, you just have to have such a different perspective than perhaps someone without the clinical experience.
Yeah, it doesn't happen as much anymore. Those decisions or those things are in conflict. But the first few days of being in the CEO role, they were coming fast and furious. Those conflicts did. I had learned previously when I took the CNO role, because I think all of us, when we are somebody's employee, we all get that idea sometimes. If I was the one making the decisions, this
Right.
is how I would do it. And I learned very quickly in that role, in that interim role, that you know what, you only know about 1/18th maybe of what you need to know to make those decisions, and it's never as easy. So I do in those decisions where my clinician and my administrator personalities conflict, I do go back to what is the important thing for the patient. If there's a
Yeah.
patient involved in the situation, we're going to do what's best for them first. And at the end of the day, too, even those decisions that aren't emergent or urgently made right then, if we can look at it from the perspective of how does it benefit the patients, and sometimes that is, how are we benefiting them by making sure that we're financially stable and we're
Yeah.
here 25 years from now. So
Yeah.
but still just framing it from the context of what's best for the patient, which
Yeah.
an individual or the community.
Yeah. Well, has that shaped? I mean, you bring up a good point. When you were a clinician, right? Some of the decisions that were being made at the administrative level, you only knew a fraction of why those decisions were being made. I'm kind of curious. Has that shaped? I mean, even a small critical access hospital like Pershing, you guys are probably a big family, right? To a certain degree, and there might be knowledge of what's going on, but has that shaped your communication strategy at all, and the way when let's say pivotal decisions are being made by virtue of the way you communicate it to your own staff, to your own population?
I think so. I think being a clinician, you're always in the mode of educating and trying to explain to your patients the whys. I need you to take this medication
Right.
because, and it's going to do this, this, and this. And so I try to do the same thing with our employees when I'm making a decision, especially one that may be not completely popular or might be stretching, changing something that we've done or stretching what we normally would do. I try to be transparent as much as I can
Right.
with the whys. I feel like for myself, if I understand why we're doing what we're doing and how I fit into that, then I'm a little more apt, even if I don't agree, I'm a little more
Right.
apt to comply and get on board.
Yeah. Well, let's dovetail that into kind of a question that I think brings this a little full circle. When you first became CEO, what was the biggest adjustment you had to make moving from the clinical mindset to the system-wide leadership role? I mean, we've kind of hit and maybe danced around this, but did you have a moment of epiphany where you thought this is so far different than the types of decisions I had to make previously?
Yeah, yeah. Pretty much, I can't think of a particular instance, but I know pretty much within that first week, it's like, this is so much bigger than what I did. And I remember having a conversation with my husband. I can't, like I said, I can't remember what that decision was, but I was like, all of a sudden, I felt the full weight
Right.
of the responsibility. And it's like, I go to bed every night knowing that there are 165 or 161 families that are relying on me to make good financial decisions for this organization because that's how many employees I have. So all of their families are impacted. And then you realize that there's a larger community. The county that
Right.
we serve is about another 10,000 people. So, there's a lot of people that are relying on me to make good decisions and things. So it was kind of a scary thing. I would kind of say that probably that first couple of months, I was like, oh, what have you done? Well, how did you let yourself be talked into doing this?
Right.
But it's gotten better. I still have moments like that. I had a situation here a couple of weeks ago where that clinician in me can't turn off. And so there was a situation, it was somebody that had been one of my previous patients, they were dealing with a crisis and everything. And so I felt like I could help and interjected. And I was fortunate. I had a very nice physician that told me after it was all over, he goes, in all my career, I have never had a CEO involved to that level on a case like this. And so that was a nice reminder that, that's not my lane anymore. So,
Which it came from a spot of appreciation, I'm sure,
yes,
but you
yes.
took it how I would, what makes sense for you to take it that way. I mean,
Right, right,
I'm sure there's a part of you who's like, when you stepped into this role, if not me, then who, right? And we didn't
right.
really touch on when you got into that role, if there was an external search, or if you even had trepidations moving into the role, or other candidates, et cetera. But, I don't know how much we'll get into it today, but just like recruiting a rural physician, right? I mean, if you can recruit someone who is from the uh, the county, from the
Community, yeah.
community, the likelihood of them staying there is much higher, right? So, and I'm sure that had to go through your head, right? If not me, who's
Who?
going to be here for the sustainability of our community in this role?
Absolutely. That was a question, and our organization did not do an external search, but it is very similar to recruiting for a physician. You know, they already knew what they had in me. They knew I was committed to the community. I
Known
had been
quantity.
here. Yeah, yeah. So they already knew what I brought to the table as far as commitment to the organization and to the community. But it is that, when you look at things, and it's the same thing with physicians and other, leadership roles, finances are limited. And so we cannot compete with different organizations for the top talent. Not that we're settling for any less. I don't feel like I'm less than another CEO, but you do have to realize that the competition is fierce for that. And so my concern was, is if who is going to take this role,
Right.
if not me. And not that I'm the end all be all for Pershing. I'm sure there's other people in the organization that probably could do every bit as good. But I know that I feel very strongly about this organization and the importance of it. And I didn't grow up in this community, but my husband's family is from this community. And so I can walk down this hall on any given day and run into somebody that's a family member in some way, shape, or form. I run into my neighbors, our friends, our things. And so it was extremely important to me that the person who leads this organization is able to see the future for the community and value what this facility and organization means to the community, and make sure
Yeah.
that we are here for the next 50, 60 years.
Right. Well, in a world where, in an industry where everything is quantified, we're looking at
Yep.
numbers all of the time. So much of what you bring to the table, you can't quantify, right?
Right.
And I think that's fantastic. So I mean, Pershing Memorial, you're a critical access hospital.
Yeah.
For our listeners and other leaders out there who may not work in critical access hospitals every day, what makes a CAH fundamentally different from other hospitals?
So I would say it is maybe some of the reimbursement. So it's a designation. Hospitals are, when we're licensed, we have different designations. And so we're designated as a critical access hospital. And that means that we are kind of a necessary provider type thing. We provide 24-hour a day, 7-day a week emergency room coverage. We have an inpatient unit. We have some general things, we have labs, and we have other things too. We have therapy, swing beds, those types of things. So we provide the minimum necessary in some cases, which is the 24/7 emergency room and inpatient unit. And in return for providing those services in that critical access way, we get a different form of reimbursement, so to speak, from Medicare. So in a community like mine, Medicare accounts for 65% of the patients that I take care of. So it is my largest payer. So we have a thing at the end of the year that I liken to my tax return that I have to do as a critical access hospital. It's called a Medicare cost report. And so we go through everything that we do here, and they break it down to what it cost us. And then Medicare reimburses us 101% of our cost. So, but with that payment model, then I have to agree to certain things. I can only have a certain number of hospital beds. I can only keep patients for an average of 96 hours. So if I have somebody who's ill with something that's going to take more than that 3 to 4 days, then we have to send them somewhere else for care. I can, yeah, those are kind of kind
Yeah.
of my limitations.
Yeah.
There's limits to those things, but making sure that we're financially stable through that reimbursement strategy with Medicare is kind of the main thing.
Sure. Well, there's limitations, right? But I mean, the designation itself has so much value.
Yes.
I would imagine trying to stay within those confines is mission critical. I mean, you mentioned having to refer out, being so rural. How do you approach partnerships with some of the other systems you work with? And what would you say some of those challenges and opportunities really, as you've been in this role to foster those relationships? Because as I've heard, not being in the position, it really is all about relationships, just like everything else.
Yeah, it most definitely is. We try to have very good relationships with all of the tertiary care centers around here. Now, one of the things being designated as a critical access hospital is you have to have an affiliate agreement with a designated tertiary care facility. And for our facility, that's Boone Health. And we've had that relationship with them, I believe, as long as we have been a designated critical access hospital. But again, you still have to have other relationships. I mean,
Sure.
Boone can't take everything that we have for various reasons. Sometimes they don't have the beds, sometimes they don't have the specialty. So we try to make sure we have good, strong relationships with the hospitals in Kansas City, University Healthcare, also in Columbia. Sometimes those referrals go places as far south as St. Louis if we have to. So during COVID, we really had to lean very heavily on some of those. Kirksville is another tertiary care facility that we partner with a lot. So having those good relationships with them and making sure that we maintain those is very important. We
Yeah.
also we'll partner with them on some specialty care. I mean, just we're not limited to just those things, the emergency room and the inpatient care. So we do, through some of those partnerships, also have specialty care here that comes over. The St. Luke's Hospital, they send people, physicians over to do our podiatry. We have from Boone Health a pulmonologist that comes here. So we partner those in those directions too, so that we can bring some additional services to our community.
Yeah. Well, and revenue, vital revenue for the hospital, right? I mean,
Yep.
we know, and I'd be curious of your perspective, as a rural healthcare leader, that what a difference it makes that the care can happen there, right? How many families won't or can't travel, right,
Right.
for necessity services, and a lot of us who maybe have to be empathetic to that because we might not be in that situation, but I'm sure you see that every day, the impact of not having a specific specialty or being able to serve, which must bolster again just your role and give you that gratification that we are doing something meaningful because this community needs it.
Yeah, absolutely. My goal is if I can save the average patient or family, 2 or 3 trips a year to Columbia or Kansas City for a specialty service, then I feel like that's where I'm meeting my goal to meet
Yeah.
their needs. I tell people, here it's a scenario that I have, but it's the one that drives when I'm thinking about specialists and different things. Where I live, and I live even more rural than what Brookfield is. I had neighbors on one side of me where the wife had dementia and the husband had macular degeneration, and they did not have any children of their own. And so they had support from family and friends and stuff, but there was needs for specialty care for them. And times when they didn't have that, these two people were on the road traveling to get care, and neither one of them needed to be behind the wheel of a vehicle. And so I use them in my mind as I'm trying to find, what service would be important for the community to have here to make sure that I don't put people on the road, because it may be me that is on the, it may not be them that is the person injured in that
Sure.
travel. It may be me who's on the road and things. So it's very important to me that we provide those services, as many
Yeah.
services as possible here, to keep people home a lot more often.
Yeah. Wow. Well, and of course, that's indicative of all of the situations, a broader population that you don't know, right? And
Right.
so I love that you're able to take real examples from your community and maybe even bring that into different innovation or different things that you can think outside the box. How do we serve,
Right.
for these community members? I do want to shift gears a little bit. Tell me a little bit about what might be often misunderstood, right, about critical access hospitals, especially from the standpoint we've talked a little bit about Medicare. There's obviously other payers out there, but especially from the perspective of the payers and even policymakers. There's been obviously a lot going on these last few years with Medicaid and different reimbursement. But I'm just curious, kind of what you feel might be misunderstood.
So I think that they don't truly understand what rural looks like, and they don't understand all the variations of rural that is out there. And I think that goes for both policymakers and payers. I have 161 employees here. And so we have to cover all of the different things, not just the direct patient care, but all the behind the scenes administrative type things. And so from the perspective of payers, they have a lot of hoops we have to jump through and things. And so they don't understand that I don't have the bench depth in a lot of things to be able to meet all of those little demands and stuff. And in ways, it causes problems within our sometimes we just can't get back to those denials as quickly, or it seems sometimes they'll throw out just a big bucket of denials, and like they know we can't work through all of them. So I think, and the policymakers are the same way. I mean, it's I see things that come out in legislation and stuff, and I'm like, how in the world do you really expect? I have 161 of us, and most of us are wearing three to five hats at one time, and so I can't possibly comply with all of those different things. And my finances are not the same as like I said, rural is not rural is not rural. There's a lot of different variations.
Flavors. Yeah.
Yeah, and I mean, I'm fortunate. I'm not like one of the smallest hospitals. I'm not the smallest hospital in Missouri, but I am one of the smallest. And so it is hard to comply with some of those things. So I think policymakers, it would be really important for them to really get out there and see the difference in the variation in the rural hospitals that they have, so that they can kind of see real world what they're impacting with these decisions and these regulations that they feel like are supposed to make people safer, but really in the long run they're taking away from the bedside care and the direct patient care, because we're having to do all of this administrative burden work to comply with some of these regulations.
Well, again, that's why kudos to coming on this program. Hopefully this messaging will reach some of those policymakers, right, in an aggregated format when we hear the voices from other leaders like yourself. But you mentioned denials, right? It's a big part of what you have to deal with the payers, and there's relationships there and there's realities. But tell me, I'm privy to some of the innovation that you've brought to Pershing to combat some of that, right? You mentioned they flood you with it, like they may expect you never to be able to get through. But tell me how you've pivoted and created really a department to help with that.
Yes, we learned back, I'm going to say 22, 23-ish, that we were seeing a lot of denials based on lack of prior authorization. And so as we started diving into that, I had a new revenue cycle director at that time. And as she started to kind of get comfortable and familiar with us, what we found is that prior authorizations were being done by whoever had the time to do them, that had the closest contact to the patient. And a lot of times that was my registered nurses. And so I have registered nurses who are one of my more, expensive resources within the organization, that should be the ones giving the bedside care and doing that. And I have them tied up for hours on the phone, because prior authorizations are not something you can get quickly. I have them tied up for hours. And so looking for a way to get those resources back to the bedside and cut down the denials, we started a prior authorizations department, and we started with one individual. And we were very fortunate that this person came to us with already some previous experience. So
some previous battle scars, probably.
Yeah. So while it was a new department for us, it wasn't necessarily a new role for her. Yeah. And within that first, I'm going to say 6 to 12 months, we saw about a 50% reduction in our prior authorization denials for lack of prior authorization. And so made a few tweaks and changes. We're able to take somebody that was doing that same role in our rural health clinics with some other things and added them to that department. And so we had two people who then were doing all of the prior authorizations, or I can't say all, about 99% of them. If there's an urgent one that comes up, nursing may still be doing that, but most of the others are being done by this department of two, and they're doing a fantastic job. They're knocking it out of the park.
Yeah.
I don't know how we got along without them. We're not seeing a lot in the way of prior authorization, lack of prior authorization denials. It's still a work in progress. They do all of the clinics, all of the outpatient procedures, imaging studies, those types of things, surgeries,
Yeah.
all of those things. And then they also do some crossover help with prior authorizing for inpatient stays as well. We do swing beds, and some of those managed Medicare require prior authorization for those, so they do a lot of those as well.
Yeah. Well, now that you have, I mean, that's fantastic. And that's just a cool story, even if that was the only snippet we had from this interview. But what do you think now that you've got some dedicated folks for working on these pre-authorizations? Have you guys learned? What have you learned, I guess, to maybe even streamline that process, right? I imagine when it was your nursing staff who was just ad hoc, this was just a part of what they had to do, to your point, wearing three hats. But when you have at least one person and now two, I guess, kind of in a hybrid role, have they had any revelations to say, there's a way we could make this process better, or is it just you've chalk it up to it is what it is. This is what we have to deal with, and we're glad that we now have a department who is solely, like you say, 99, almost solely responsible for making sure we, work to get our patients the care they need.
Well, I think prior authorizations, just in general, they are what they are. However, we learned in this process that were a lot of options that we had that we didn't realize we had. Technology is a wonderful thing when you use it. And so, they have been able, some of the processes were streamlined, some by being able to use that, a lot of the payers have portals or things to go on and ask for those prior authorizations. So a lot of them are done that way. Also having education and things with our providers, making sure that the proper documentation to support what you're asking for is in there the first time and timely, so that as those people are submitting medical records and things like that, to be able to get those prior authorizations. So we found a lot of things within our internal processes that needed to be addressed. And we're making some significant progress with those. But I think to some degree, we're almost at the point now where we have fine-tuned the processes enough that we're just at the point of it is what it is.
Yeah. Well, I mean, obviously critical access hospitals, right? They're essential to access. We've kind of touched on that a bunch here, but financial margins, as you indicated, they're razor thin, right? So how do you think about sustainability while staying true to your mission? And what does that even look like in the coming years from what you can tell?
Well, it's, for me, I tell people it's not an option for Pershing not to be here. So we'll just have to
We'll figure it out.
Yeah, we'll have to figure it out.
Yeah.
And so we have been very fortunate that in the time period that I've been the CEO, we've been through our community health needs assessment. And then we also did a strategic financial operations assessment. And both of those gave us a lot of insight into our community, both the age of our community, where the direction of the community is going as far as population, and what those needs are going to be for those people, 5-10 years down the road. And so my strategy has been to find those services that are going to be meaningful for the people in the community in the 5-10 years down the road, and try to build those. If we already have them, let's build on them. If we don't have them, how can we get them here?
Right.
And then I think we need to embrace strategies that are not usual and typical for getting those services here. Having an elderly population, not all of them are tech savvy, but if there's one good thing that came out of COVID, it's that we all learned how to use our technology a little more. And
A little bit
so,
better. Yeah.
yeah, and so some of them, while they may not be familiar with a telehealth platform, they know how to use FaceTime because that's how they kept in contact with their grandchildren or their children during COVID. And so they're a little more open to that now, but leveraging telehealth. Right now, we are doing something here in the hospital out of necessity, not that I wanted to, because anytime you take the person out of the room and you're not able to touch, because physical touch plays such an important part in healing and things. But to make sure that we had quality care here at our hospital and were able to maintain our inpatient unit, we have a telehospitalist program that's provided to us through Boone Health. And so that's been a little trying to a little ingenuity there, trying to bring people along to understand, they're a little bit kind of put offish at first, but then after they have that first visit with the physician over the telehealth, they're like, oh, well, that's not bad. I didn't think it would be like that. And well, yeah, he can hear my heartbeat. I mean, and that's the thing. I think some of them are just amazed at the technology that's there, that you can put a stethoscope on their chest here on this end, and the doctor who's 90 miles away can listen there, just like he's in the room with them. So I think sustainability for us is going to be, it's going to be important that we leverage technology in the future to make sure that we can have more of those services here and more of those opportunities for them. Technology isn't cheap. So, it's important that we grow the services that we need so that we have the financial resources to support some of the technology that we need. We have recently developed a Pershing Health Foundation. We've never had a foundation before that supported the hospital. So looking into those opportunities for how do we get the community to support us in those ways, looking to the future. My building, the main part of my building was built in 1960. And so there's a lot of needs with that there. So educating the community on how important the hospital is, making sure that they understand how important it is that they support the hospital. And I think those are all, there's not one thing that we can focus on for sustainability. It has to be a very broad, well orchestrated size. Yeah.
Omni-channel, as they say, right?
Yeah.
I kudos to you guys for starting a foundation. I've had the benefit of spending some time on my local hospitals. One of their arms of the foundation when they really started to do outreach to the public, and really that's from my just brief time there. That was one of the biggest and most crucial parts. Is there's a lot of people that feel, why should I have to support my hospital? We pay them enough, right? And we hear that all the time. But once they realize, especially those, you might be trying to target like business owners and those in the community who must come around to realizing how vital this institution, this hospital system is to the health of the community and the viability and sustainability of the community. Once you broach that, it really, that's where the magic can happen, right? And that hopefully will take off for you. I'm kind of curious, you mentioned the community health needs assessment. Was there anything that came out of that surprised you and that steered you in a different direction that you weren't maybe as aware of or as abreast of?
No, not really, because having been a clinician, I pretty much already
The
knew.
community.
Yeah, I already knew what the challenges were. I know the reason why my chronic diabetic and chronic, pulmonary patients aren't taking their medication. It's because they can't afford it, or I know that the reason they're not keeping their appointments is because transportation is an issue. So there really wasn't anything in there that surprised me. And this is the third one we've done, and ours has stayed pretty consistent, the needs of the community.
Well, that must help with long-term planning, right? If the needs
Yes.
are staying the same. You have the basically fortitude to know that these decisions we're making for the long term, whether they be capital improvements. You mentioned your building, and which I'm sure hopefully the foundation will play a part in, right, being one of the channels to achieving whatever those goals might be in the future of updates, et cetera. But I do want to talk about a challenge hitting all rural hospitals, of not just critical access, but workforce challenges, right?
Mhm.
They've hit critical access hospitals even a little differently than some of your other rural counterparts. So, how do you approach staffing when you need generalists, flexibility, and specialty coverage across multiple roles? I know you kind of mentioned partnerships play a huge role there, but for the you know clinical roles you need there in the community and generalist roles, how do you approach that, and what do you think's been effective?
So it has been a challenge, especially since COVID. A lot of people left the workforce for different things, and a lot of people view work different now. Then we have the whole generational thing.
Right.
Um, I don't consider myself to be elderly by any means, but there's definitely a disparity between my work ethic and the work ethic of people that are just coming out of college and stuff. We all view work differently. And so it has been a challenge, especially in a rural community. And people are so traveling is not anything that people are averse to anymore. So where when I started out, I didn't want to drive an hour and a half every day to work to be able to work. So you picked kind of local to your area, and that doesn't seem to bother people anymore. And then there are so many options for remote, that there weren't before, and different options. Physicians, nurses, therapists, all of them have opportunities through the telehealth platform and stuff. So it is a struggle. We've been very fortunate to keep a fairly consistent staffing here, and have only occasionally had to use travelers periodically since COVID was over. But it is becoming more and more challenging. We also, in our community, we have 3 long-term care facilities and 2 other primary care offices in the county. So we all compete for the same nursing staff, the same physical and respiratory therapy staff, and those types of things. So it does have challenges. We just try to, we just try to think about, what's best for our employees and best for the patients, and try to meet their needs the way we can, trying to be generous with vacation time, be competitive with pay, trying to find those extra special things that we can do that kind of set us apart from some of the other employers. But we are struggling with that. And one thing that we're looking at right now is reaching people before they leave high school. I think that's the one. And I know I've had conversations. My youngest child is a junior in high school, and I know I've had conversations with them, it is not a requisite for life that you have to go to a 4-year university and receive this, bachelor's or master's degree for every career, and come out with tens of thousands, if not hundreds of thousands of dollars worth of debt. So making an effort to get to the kids in the school, making an effort to make sure that they have a lot of job shadowing opportunities here, that they can meet with our different departments and department heads to talk about it. I know for my own child, we've had that conversation. She happened to be listening in the early days of my CEO when I was struggling for lab techs. And she was listening to me on the phone one day, and so she asked me, she's like, "Is that a lot of money?" What we were talking about, the annual salary for a lab tech. And I said, well, I mean, it depends on what what your goals are in life. And so we had a conversation about the different things. And, I'm like, here, this is what a $60,000 a year life looks like where we live. But
Right.
if you're looking at someplace like Columbia, this is what a $60,000 a year job looks like. So, the perspective of that. And so we talked a lot about it. And I thought, I bet there's a lot of other kids out there that don't realize also, a lot of the roles that we have here, they can get through the community college or the junior college. And a lot of the schools in the state are A+ schools. So, if you take a career where you go through that, you have some financial help with that.
Right.
And then there's a lot of different programs out there to help people on the backside with student loan repayment if you're working in areas of healthcare shortages. And then facilities like mine, we're willing to, if you come work for us for a period of time, we're willing to help give you some money to pay back your student loan. I'm very passionate about that because that was part of how I received my master's degree. Pershing supported me to a certain extent, and then there were programs out there that when I finished, as long as I agreed to work 2 years, they gave me so much money to pay back my student loans.
Yeah.
So by the time I finished my master's degree and spent my first 5 years out being a nurse practitioner, my student loan debt was forgiven.
Wow.
So I think that's very important for people to know that there's opportunities for careers out there without you having to start your life in extraordinary debt for education. Yeah.
Yeah. Well, I mean, articulating that, you mentioned how you're in competition, right, with even local facilities, and being able to articulate all the different things, right? Being a rural access hospital, you mentioned earlier, right? We may not be able to pay top dollar every time, but a lot of these other benefits, when registered by the right person who resonates with what they're looking for in life, to your point, what are your goals? And tying that back into grabbing kids out of high school or in high school to either determine, is this a route or is it not? Right. I mean, because there's those students too who, I imagine maybe have thoughts of going into whether it be a doctor or a different kind of clinician, but because they had that exposure in high school, they could easily weed out. I'm a perfect example.
Yeah.
I could not look at blood. I never had a shadowing opportunity in a clinical setting, but my wife is a physician assistant, and I marvel at what she's able to do all the time, whether it was
Right.
when she had her stint in surgery and now being in more of a clinician setting or clinic hour setting. But I mean, how do advanced practice providers, including NPs and PAs, help critical access hospitals maintain access to care, especially in primary and urgent care settings? I know we've kind of talked about their importance, but I know in rural health, it's got to be compounded, right? Because your ability to recruit some of maybe the physicians and even in advanced practice providers above mid levels is just difficult.
It is. And what we're hearing is that, we're looking at, I mean, we have a shortage of physicians across the country as it is. And I believe within the next 10 years or so, they're estimating that we'll have another $150,000 or $50,000, 100 to 150,000 fewer physicians than we need to cover the population of the country. And so we can't we can't keep continuing with that deficit, and it makes it a lot harder for facilities like mine to recruit physicians when the pool of candidates is getting smaller and smaller. So advanced practice providers have an opportunity to fill that gap for patients and provide access here. I know I have a hard time all the time explaining to people because they're like, well, you're my doctor. No, I'm a nurse practitioner. There is a difference between the two of us, but yet we fill roles that are very similar at times, but we approach things differently. But advanced practice providers offer that opportunity for people to have primary care here with somebody that they trust, that can, somebody that they know, that can give them that constant feedback and support and things that they need. And we do it in a way that is holistic and safe and appropriate for the people that we have. And we have good partnerships. That was one of the things, being a nurse, I bring education to everything, and having the opportunity to do that with patients, I think, is very important because you have a lot more opportunity to impact their long-term care when you have that time to take to educate them on the whys you're asking them to do, the things you're asking them to do. So.
Yeah. Well, I mean, again, operating at the top of their license,
Mhm.
uh, there's a lot there I had to learn, right? And
Yeah.
I imagine everyone is the same way. If you're not coming from a clinical setting, and even those that are, I've found don't even fully understand what those professionals are able to do. And so,
Right,
what I mean,
right.
constantly surprised.
Yeah, that's a whole soapbox for me about letting me practice to the top of my license, because as we still go, we go on, and the physician shortage becomes shorter, becomes more profound. You're also looking at problems with being able to find collaborating providers for those nurse practitioners, and sometimes those collaborating providers can be, states away possibly, and they don't understand the community that you're serving, and
Yep.
yet they're limiting the things that you can do, because they're not familiar with. I have a whole soapbox about advanced practice providers being able to practice to the top
Yeah.
of our license, and I hope that's something that we see here in Missouri before too much longer.
Yeah. Well, I was going to follow that up with, and feel free to soapbox or not, but I mean, every state is different. And as
Yes.
I'm sure you're well aware, how do you feel, for a policymaker hearing this? I mean, how do you feel Missouri could better, maybe innovate in that regard to allow, especially in rural areas where it's critical, um, more flexibility to be able to, perform duties at the top of your license, and where do you feel like we're a little restricted here in the state of Missouri?
Well, I think here in the state of Missouri, the fact that I have been in practice until I became the CEO. I mean, we're talking 25 years I have had been in practice with the same community. And so I'm very familiar with the community, with the needs of the community. I have a very robust experience to pull from, but I am still limited in the things that I can do. I have to go almost like get permission to do what I know is right for the patient in front of me, and that's very frustrating. And sometimes it can lead to delays in the things that the patient needs if I don't have access to my collaborators. Now, I've been very fortunate. Most of my collaborators and I have worked on site together, so access is a lot easier for me, but that's not the case for every nurse practitioner in the state. Some of them, their collaborators are not on site, not readily available for them. So one thing that in the course of my career too, I have served as a preceptor or a mentor for students who are going through various NP or PA programs. And I do understand what the physicians are saying, that, we don't come out with the same experiences that physicians do and things like that. So I believe there's a middle ground for between nursing and physicians in that, and I think there's a path forward to full practice authority for nurse practitioners through maybe a transition to practice
Yep.
option, so that new nurse practitioner that's coming out that's unsure of themselves and doesn't have as robust of an experience behind them has an opportunity to learn and grow in a supported and safe environment for the patients and for that provider too. So I think transition to practice is something that I really hope that we look at as a possible middle ground, place where we can compromise to
Yeah.
get, because the shortage of providers is just going to get worse. And so here's a good resource that we have, and they can do the job. So let
Yeah.
them do it.
Let
Yeah.
them do it.
Yeah.
Let them run, right?
Yeah.
Let's shift a little bit to the broader economic impacts. I mean, in a rural community, the hospital, and in your case, I imagine is the same. You're often one of the largest, if not the largest, employer. How do you think about your role in the broader economic health of Brookfield and the surrounding area, carrying that status?
It is something that we take very seriously, because I have 160 employees, and so
Yep.
that's I should have gotten that information we got on here, what our annual payroll is, but I mean that's a fair amount of money that is in this community, that goes to buy services and goods and things like that. So if we aren't here, and those 160 people don't have jobs, then that's a large amount of economy that's leaving the community to go somewhere else. It also makes it a little bit harder for people in the community when you don't have a hospital. They don't think about the fact that insurance rates go up, and because you don't have access to an emergency room, it impacts, employers the same way when they're talking about work comp type coverage and some of those different things. So there's a lot of financial impact outside of the hospital if you don't have a hospital here. When we're here and we're keeping people healthy, we're keeping the community healthy as well, financially and physically.
Yeah. Well, for a broad number of reasons that makes, I mean, it makes total sense. So, and I know you guys have recently in our brief discussions, right? You talk about insurance rates, work comp. I mean, you have recently within your own population partnered with the Health Co-op of Missouri, right?
Yes. Yep.
Which I've had loads of experience being an employee benefits professional, working with various systems, but also the employers in the area to say how can we as a community better support our hospital and have a partnership with our hospital that stretches beyond what the confines are of working through an insurance company, right? Or a major insurance company. So kudos to you guys. Hopefully you'll see. I'd be curious to see have any of the local employers. Have you seen any shifts or conversations start to happen?
Yes, as a matter of fact, we've had a couple of conversations that started that way, and we're like, well, we're part of the, or we've joined this, and they're like, oh, we heard about that and we were thinking about it. Now that we know you guys are in, we'll go
Right.
ahead. Yeah, we'll go ahead and do that.
Set
So
the precedent. Yeah.
yeah, it's been very interesting that we didn't realize there were so many people that were kind of holding off of that. So yeah, we're interested to see where that goes.
It's the common, well, you think this is a good thing, but why aren't you doing it for your own employees, right? So
Right, right,
and turns out to be a benefit in most
right.
cases, all the way around, which is rare to find, I feel like, in this healthcare environment, especially as it relates to insurance topics. But talking about clinicians, for clinicians who may be considering, similar to you years ago, leadership roles, what advice would you give them, especially those practicing in critical access hospitals?
So I would say if there's ever an opportunity given to you, you should say yes. Even if it is just an interim or a short term. There's more education that you need to have for leadership. I mean, just because you can lead patients individually and maybe lead your small areas of staff, it is a lot different when you're leading an entire organization. So I have found that I needed a lot more support and education for that. So invest in yourself. If leadership is what you want to do, make sure you're investing in yourself as you go along. Take the opportunities that your organization offers you and learn from everyone you can. And there's something, you can take something away from about every leader you come in contact with. Some of them are positive
Oh
lessons that
God.
this is what I need to do. And some
Right.
of them are negative lessons where you're like, yeah, well, I'm going to make sure that I don't make that mistake, or I'm not going to make that mistake again. So, but if you think leadership is a track, and even if you don't think leadership is a track you
Give
want
it
to
a
take,
try.
yeah, give it a try, because you don't know where life's going to take you and what opportunities are going to come at what time. So be prepared for them.
Well, I mean, right. I mean, this is transferable, right? So
Yes.
whether you're in healthcare or not, the experience you've gained in leadership, and that would be the same at an insurance brokerage, at a hospital. Um, those skills are transferable, in a sales role as a producer, right? I'm tasked with understanding the needs of my clients and coming to the table with solutions, but rarely do folks in my position, and I've had opportunities in leadership as well, but you know, managing people, managing the broader focus of the organization is you don't get that perspective being siloed into being an individual contributor, right?
Right.
So um, if you could change one policy or perception to strengthen critical access hospitals in Missouri, what would that be? Kind of shifting gears here.
Perception. I don't know what policy, there's too many to pick from. I have a lot of them. But I'd say if there was one perception that I would like to change, it is the perception that we are less than.
Mm.
So we struggle, or I have, in my career, I have heard this term used to describe us numerous times, and that was Band-Aid station. And it is very, early on in my career, it really bothered me and kind of made me angry and stuff. And I'm trying to embrace it now and be a little more, okay, well, it's maybe not the negative, everybody needs a Band-Aid to get you through to the next type thing. So I would like people to understand that just because I am not a level 1 trauma center does not mean that I can't take care of you when you have had a trauma. Just because I am not a level 1 stroke center or a level 1 STEMI center doesn't mean that you bypass me. I have very, very skilled people here in this organization, in this facility, that are here to save your lives and to make a difference and impact those things, to make sure that you are stable and that you have a chance of survival and making it to the next place. And then once you have recovered or been through that at the next place, then you can come back here because I have skilled and valuable resources here that can help you adjust to whatever life changes you have as a result of that.
Right.
We have, great primary care providers. So I would like for people to change the perception that critical access hospitals are less than the big tertiary care facilities.
Well, I mean, that's where trust is built, right? I mean, when you know your limitations, but also when you know what you're extremely capable of, and you know that line. I imagine, and you tell me from perspective, right? You talk about patients coming back and learning. Thank goodness we have this system here, because I was able to get the immediate care I needed, and they knew when it was time to send me on, right? And so some of the best facilities, I feel like, in critical access hospitals and rural, it goes back to those partnerships, right? With other facilities. But I imagine that's where trust is really fostered, or not.
Right. Yep.
So, well, what gives you, we're kind of wrapping up here, but what gives you hope, I guess? Let's end on that. What gives you hope about the future of rural healthcare? And honestly, what still keeps you up at night?
Well, what keeps me up at night is
Let's start there.
yeah, what keeps me up at night is still, all of the different regulations and legislation surrounding healthcare and access to healthcare and coverage for healthcare, for the citizens of the country. That is concerning for me. And that is the one, because we have to work within that system that largely I have no control over. And I have a voice, but sometimes that voice is very much drowned out by people with larger agendas or bigger pocketbooks. So that's one of the things that keeps me up at night. What I have hope for is that we are hearing more in Congress and in government about the importance of the rural hospital and the importance of, taking good care of patients and making, our patients healthier and those types of things. So I hope that I'm seeing a shift in that we want to prevent disease. We want to take good care of people. We want to make sure that those people that are, sorry about that, those people that are,
Well, take it if you have to.
that we're seeing that and we're trying to make those shifts. So I feel like there's some positive things on the horizon. I think people are starting to see the importance of maintaining healthcare and making sure that the quality healthcare isn't just in the big cities, that we're able to have that quality healthcare for the people in the rural communities as well.
Sure. Well, one final question for you, Karla. What's one mindset shift that you could, believe rural healthcare leadership needs right now? And really, what's one action, taking that broader thought, what's one action these rural healthcare leaders could take this month to achieve stepping closer to that goal?
I think it is being involved in your political process. I don't talk politics and stuff with people, but it is important that you have relationships in all area, all across all political spectrums and things, and making sure that you make those connections. So when your congressman is home on, their recess or whatever, your local general assemblyman and things, having connections with them and having conversations with them so that they know that you are the expert on the area that you serve and things. And maybe at some point when they're needing that insight about what rural really looks like, they'll think about you. I try to do that at least a couple of times a year with my, for me, it's Congressman Graves and then
Yeah,
Senator Schmidt and Howley. I try to make sure and have at least reach out a couple times a year. Then with our local, General Assembly people and senators here in the state of Missouri, I try to touch base with them, as frequently as I can. We see them in the communities more often than
right.
we would the others. But inviting them to my facility and my organization to see what life, my goodness, is really like here is kind of an important thing, is to let them come and see what rural is and what your
Right.
facility does. And I think that's one of the things that I didn't realize as a when I was a provider, how important it was and how much I would need the support of those individuals in making sure that my hospital can stay open.
Right. Well, again, if not you, then who, right? And
Right.
so I think you've shared an enormous amount of your expertise and perspective, and it's seriously been invaluable. I can't thank you enough for coming on and being one of our first guests. So, thanks again, Karla. This has been fantastic. I'm gonna let you get back to those phone calls because work doesn't stop. And while this is a big piece of giving rural health the exposure it deserves, and rural health leadership specifically, again, you've got things you got to do, and like you said, you're wearing a lot of hats. So I'm going to let you get back to it. But thank
Okay.
you again, Karla. This has been
Yep.
great.
Thank you.